upload your presentation immediately in the hall upstairs.
Next session is Dr. T.K. Raman Memorial Oration by Dr. Abraham ITTYACHEN, Professor and Head of Department of Medicine, MOSC Medical College, Kolancheri. We welcome you, sir. To chair the session, we welcome Dr. Anil Kumar, President AP Kerala Chapter, to the dais.
Good morning to all of you. So as custom demands, we have a T.K. Raman Memorial Oration in each annual meeting. So this year, the Executive Committee has chosen none other than Dr. Abraham ITTYACHEN for this prestigious event. To be awarded an oration, a person requires certain credentials, and he fully meets those requirements as a teacher, academician, and AP member, long association with the AP. So Dr. ITTYACHEN, before I go to Dr. ITTYACHEN, I'll just tell you briefly about this oration. This is Dr. T.K. Raman Memorial Oration. So Dr. T.K. Raman is not known to any of us. None of us have had occasion to be with him, except probably Paulo sir. Paulo sir may know Dr. Raman personally. So he was a very brilliant student and one of the earliest physicians in Kerala. He is a product of Madras Medical College, having done MD there, and DTMH, that is Diploma in Tropical Medicine and Health. And he has been the first Malayali principal of Trivandrum Medical College. Prior to that, an Englishman was principal of Trivandrum Medical College. So he started the medicine department in Trivandrum, and he was very instrumental in organizing the cardiology department, pharmacology department. He worked in so many departments. At that time, these other departments were not active, so he had to undertake the responsibility for those departments also. And he organized the APA National Conference in Trivandrum in 1958. And has had several publications, almost 300 publications in Indian Medical Gazette. And he is a tropical medicine expert. Kala, Asar, malaria. In fact, he was also a co-founder of malaria in India. Ronald Rose, describing malaria. Discovery of a malarial parasite is partly credited to Dr. T.K. Raman. So he's a great teacher. So it's on behalf of T.K. Raman that we hold this oration. And to give this oration, we have Dr. ITTYACHEN here. Dr. ITTYACHEN is a product of Calicut Medical College, 32nd batch. And he did his MD in KMC Manipal and critical care diploma from Madras. And diploma in epidemiology also from IIPH, New Delhi. And he has several publications to his credit, almost 30 publications in national and international journals. He has done several work in leptospirosis, use of methylprednisolone in ARDS related to leptospirosis. That is one of his most important works. And also his other important work was scrub typhus. He described scrub typhus in India, in Kerala. And formerly he was working in CMC Bangalore as a lecturer, and currently is Professor of Medicine and HOD in Kolancheri Medical College, MOSC. Over to you, Dr. ITTYACHEN, please.
Thank you, sir, for that introduction. At the outset, may I thank the Executive Committee of Kerala State Chapter for having given me this oration. It's a great honor. I also would like to salute the memory of Professor T.K. Raman, in whose memory this oration is named. The title I have chosen for my oration is My Journey with Steroids and Leptospirosis, a very satisfying journey. As I proceed, you will understand why I call it a journey. It all started in 2003 January when I joined my present institution as an young lecturer in medicine. Before that, I was working as a lecturer in medicine and critical care in CMC Vellore, and as Providence would have it, so I believe, I was attached to a unit that was looking after the medicine ICU. At that time, there was no critical care department in CMC Vellore. Under the inspiration of Professor Dr. John John, who was the Professor of Medicine, who had done his critical care training from Australia, I went to Madras and did this course. At that time, critical care was almost unheard in India. There was no DM critical care, no DNB critical care, and no one knew who an intensivist was. So I went to Madras and underwent my training under Professor Rami Rajagopalan, who was one of the founding members of the Indian Society for Critical Care Medicine. Currently, he is the head of the Department of Critical Care Medicine at Sri Ramachandra Medical College, Poro. And then I joined my present institution. When I came to my institution, I was bringing with me a new speciality. No one knew what it was. I was told to look after the medicine ICU also. And there, I met a new disease called leptospirosis. Until then, I had learned about leptospirosis, but never seen a case of leptospirosis. In Vellore, I had managed scrub typhus, an occasional anthrax, malaria, all coming with ARDS, multi-organ dysfunction, but never a case of leptospirosis. And the situation in my hospital was very pathetic. Very high mortality. Patients came in late, all developed MODS, ARDS, and 97 to 99% died. I would not be lying if I say nearly 100% of them died. A portfolio of treatment was being offered, exchange transfusion. There were some papers which said that you remove 250 ml of blood and you transfuse 250 ml of fresh blood, the amount of antigen load comes down, but it never worked. People who developed ARDS were put on the ventilator, no one survived. People who had developed renal failure underwent dialysis, no one survived. The bottom line was no one survived. In the end, there would be two victims. One was a poor patient, because most of them were poor, often the only breadwinner in the family. And I had also problems because I had no one to discuss. There was scanty literature available. Now, unlike now where we have social groups, EPA social groups, where we can discuss, nothing of that existed that time. And to contact my professors in Vellore or Madras was not that easy. And often it was difficult to tell the patient's wife, whether we should ventilate the patient or not. Because if you don't ventilate, 100% he dies. If you ventilate also, 97% he dies. So it was a very dicey situation for me. If you do also, you are damned. If you don't do also, you are damned. So in the end, I would be creating two victims. One was a poor patient and the other was his family, who would be again pushed into financial penury. So it was actually, to be very frank, a lot of emotional trauma for me, because there were a lot of deaths around. So I thought, well, could there be an alternative? So I went back into literature, searched, but frankly nothing was there, and I thought I will go back to my experience also, because I was a trained intensivist. During my critical care training, I had heard about this called ARDS network. To those who are not familiar with this is actually a network established in US in 1994 by the National Heart, Lung and Blood Institute and the National Institute of Health. It was a network of 42 hospitals, and they were to test promising agents, devices or management strategies to improve the care of patients with ARDS, because ARDS was becoming a big problem around the world. Now, these were the hospitals that participated, but mind you, all of them were US-based hospitals. There was not one hospital from a tropical country. And one of the first studies that came out from this, in fact, so many studies have come, which is available on the net, and most of them are freely downloadable. Some of them are not freely downloadable. One of the first studies was the last study, late steroid rescue study. The study was done between 1997 and 2003, but it was published only in 2006 in the New England Journal of Medicine, but it was already there in the ARDS network site. And their conclusion was starting methylprednisolone therapy more than 2 weeks may increase the risk of death. So they are recommended against steroids. And you can see the patients, I'm sorry, the pointer is not working, so I cannot point, but you can see the patients who are in that study. And one thing was very clear, there were no patients with a topical infection and definitely no leptospirosis. So that was there in my mind. The conclusion that is starting after 2 weeks may increase the risk of death. And within the literature of the article they had written, sometimes in some subsets, if you give methylprednisolone early, it might work. So that was a worry there. So at the end, this was what was there in my mind. Use of methylprednisolone early in ARDS, would it be beneficial? And the fact that US is not a tropical country. And I had exhausted almost everything. There were no more weapons left in my armamentarium. So with the permission of senior faculty, I was the junior most person in my unit. I decided to use steroids in ARDS for the first time in leptospirosis. Actually, we had a patient who was sick, full-blown ARDS, high PEEP, 100% FiO2, fully sedated and paralyzed, and barely holding saturation at 80 to 90%. So to those who are not aware of this, I just go one step further. Normally when you and I breathe, we breathe 21% oxygen. The FiO2 of atmospheric air is 21%, and the rest is made up of nitrogen, carbon dioxide, and the minor gases. So when a person is breathing 100% FiO2 and still be holding saturation only at 80 to 90, it means that he is quite sick. And this patient of ours was not expected to survive, and I told the family. But I also told them, see, there is one drug that we can use, but I'm not sure whether it will survive. I'll try it. The family gave permission, and I used the first drug. I still remember the chronology of events on that day because that's one day I cannot forget. During my morning rounds, I gave injection methylprednisolone 40 mg stat, and I told my staff nurse, you can reduce the FiO2. So to those who are working in the ICU, you might know that critical care nurses, they are also trained in ventilator care, and we give them some leeway to adjust the ventilator settings. So every hour, they look at the saturation and they decrease the FiO2 up to a certain level. Of course, the protocol varies from ICU to ICU. Around 4 p.m., my critical care nurse rang me and told that she was able to reduce FiO2 substantially and saturations were holding. I remarked that is impossible. So I told her to follow with gases and chest X-ray. Now, gases in ICU terminology means ABG. When I came for my evening rounds, I realized that what the sister told was correct. On the ABG, the oxygen saturation had improved. We could reduce the FiO2 to around 80%, and it corroborated with the finding on the multi-parameter monitor, that the pulse oximetry. But what was most astonishing was what I saw on the X-ray. I think I have no better words to explain this. Akin to a morning fog on the car windshield melting under the rays of the sun, the bilateral opacities created by the ARDS had started disappearing. So it corroborated with what the sister told me and what was seen on the X-ray. And it has never happened to me in a patient of mine. In the subsequent days, I reduced the dose of methylprednisolone to 6 hourly, 8 hourly, 12 hourly, changed to prednisolone and tapered it over 5 days. And finally, this is what happened. The patient who was not expected to survive went home walking. Actually, I could not believe it. You can just believe, you can understand what my feeling was that. It had never happened before, and this patient, to whose family I told he will never survive, he went home walking. For me, that was a kind of a eureka moment. Now, it has never happened in my life, and my first instinct was to shout to the world, hey, here's a drug that saves lives. But that was easier said than done. In the subsequent days, I introduced non-invasive ventilation. At that time, no one in my hospital knew what a non-invasive ventilator was. With some prodding, the management finally agreed to buy. And I also refined the course of steroids. I realized that all patients did not require 40 mg 6 hourly. If they came in early, you could give 12 hourly or even 1 OD. And with this protocol, we could not only save lives, but we could also save money because all our patients were poor. Then I decided to go public, but I wasn't sure what to do. Should I go to the IMA, API, the media or public? And frankly, I was not an API member at that time. Finally, I decided to go ahead and publish, but that again was easier said than done because I had no experience in publishing. I had never participated in a study, practically nil knowledge. Now, why I tell this that the current generation of PGs, before they appear for a MD exam, they have to do a bioethics course, a biostatics course. Their thesis goes through strict guidelines as per the NMC KUHS guidelines, IEC, IRB guidelines, and they also have to publish a paper or attend a conference and present. Most of these things were only in paper during my generation. So frankly, I didn't know anything. But since I thought that this is something that was life-saving, I decided to go for the best journal. And I think lately the best journal is New England Journal of Medicine. And naturally, they rejected it. They said it was a small sample study, it was a pilot study, no control group, many technical flaws. But they never refuted the validity of the study. But still, I was happy, though it was rejected, I was happy for one reason, because the NEJM editor and the peer reviewer, he sent a detailed note explaining to me why this cannot be expected. For me, it was a learning experience. I learned a lot from that about how to write an article, publish an article. So I tried my luck closer home, and here I found success. The Indian Journal of Critical Care Medicine accepted my journal and immediately published it. They only made some change in the title. This was not the original title. It was published in 2005. I won't go into details. It was only a pilot study. In 8 patients, we had used methylprednisolone and non-invasive ventilation. And mind you, non-invasive, not invasive ventilation. And 7 out of them survived and went home. One person, he came in quite late. The family was not willing for invasive ventilation. So it was an elderly lady and she could not make it. Now I have some few cases from that time. The first one in whom I had used methylprednisolone, unfortunately I don't have the X-ray because we didn't have digital X-rays that time. Now the 2 cases which I am showing, this was actually part of my study. This was a 15-year-old male who came with the classical lepto. You can see the ARDS. His name is Vipin. This was our first generation, one of the first generation non-invasive ventilators, Respironics. Very sturdy one, but very few settings. And this patient, even with 15 liters, he was not maintaining saturation. Mind you, that was the time when there was no HFNO. I'm sure all of you know what HFNO is. It became popular after the COVID-19. That is a high-flow nasal oxygen. But I improvised one in that in the face mask, through one port I could give 15 liters and through the other port another 15 liters. So you can see the oxygen here. Patient was receiving 30 liters, and because of that, we could avoid invasive ventilation. By the 4th day, this was his X-ray. By the 7th day, this was the X-ray. And this is Mr. Vipin, that is in 2004. The next patient was a 50-year-old male by name Elias. Actually, I didn't expect him to survive because he had an alcohol problem and he had coronary artery disease. And there's one more learning experience from here. See, in leptospira, just like in syphilis, Jarvis-Eskimo reaction is very well described, and this was one such case. This patient actually came only with fever and myalgia and risk factor for lepto. We started on crystalline bench in the morning. By that day evening, you won't believe it, this was his X-ray. Severe breathlessness, and this is the classical cytokine storm, but that term was not used during those days. It came only popular after the COVID-19. And even this patient, we managed with non-invasive ventilation. In fact, some of my anesthesia colleagues objected for not putting him on the ventilator, but I resisted and I managed the patient with non-invasive ventilator. And this was the X-ray by the 6th day, and this was Mr. Elias around 2 days before we shifted him off the ICU. He had, the oxygen had come down to nasal prongs, around 2 or 3 liters. As years went by, the incidence of severe leptospirosis decreased in our institute, and they come in quite sick. But Malayalis now, the severe cases have come down, and I should admit that I was also getting old. I was no longer the young person. I've become more great. So that's who I am standing here now. As years passed by, around 2017-2018, I was preparing a talk on fevers, and I was curious to know, did my lepto-ARDS paper, has anyone seen it? Has it made an impact? At that time, the Indian Journal of Critical Care was not indexed in PubMed, so I knew there wouldn't be much citation. Later, it became indexed in PubMed. And while searching through the internet, there was a surprise. My article had found its way into the national guidelines of two nations, Philippines and Sri Lanka. Mind you, Philippines and Sri Lanka are two nations where they have a severe leptospirosis problem more than us. Both of them are tropical nations. Now, this is the guidelines from Philippines, clinical practice guidelines published in 2010. They have modified it slightly recently. It is freely available in the net. Anyone who wants to download it can do it. Very beautiful guidelines. They have given organ system by organ system, the complications as well as the treatment. I just show you the part relevant to me. What is the role of steroids in pulmonary complications? They actually give it question wise. I just read that sentence. The evidence for use of steroids in ARDS is conflicting, but studies have reported to be useful when used in early ARDS to leptospirosis. Reference 20 to 21. And when I looked at the reference, the first one was actually my paper. The second one was actually, not surprisingly, another paper from Bombay. It was actually a study where they had used a higher dose, but they had not mentioned anything about non-invasive inhalation. Even that you can download from the net. The other guidelines was from Sri Lanka, published in 2016. There they are mentioned that if you give steroids early, it will improve the prognosis and reduce or delay the need for mechanical ventilation. And when I looked at the reference, only my study was given as a reference. So I decided to look closer home in India, what was happening in my country. And one of the first guidelines that came out was in 2006, a joint guidelines by the National Institute of Communicable Disease and the WHO. Here, they had just mentioned that the commonest cause of death is pulmonary, and patient has to be shifted to a tertiary care center. And regarding the treatment, organ specific, they just mentioned the treatment of these organ involvements does not differ much from the same manifestations due to a non-leptospiral cause. No mention of steroids was there. Then the next guidelines came in 2013. It's actually our own guidelines from the APA textbook of medicine. They just mentioned ventilatory support for respiratory failure would reduce mortality. Then 2015, the last guidelines from the Government of India, the management of organ involvement does not differ from that of non-leptospirosis. Again, no mention of steroids. Then closer Kerala, I just was curious what was our government guidelines. This is what I got from the DGHS website. There is one guideline, but they have not mentioned the date. Here they have mentioned regarding ARDS, they have mentioned that non-invasive inhalation was good for mild ARDS, that was a good suggestion. And they have also mentioned about this word, the ARDS network protocol, which meant that the group that had generated this, they had already gone through the ARDS network protocol. But again, no mention of steroids. Then in 2002, one of the best guidelines from the Government of Kerala came, very beautiful guidelines. Now regarding the pulmonary one, very beautifully they are given, I'm not going to the details, but for the first time they are mentioning steroids and leptospirosis. That was in 2022. Now this is regarding leptospirosis, but this doesn't end there. The story doesn't end there. In 2019 we know that COVID-19 started, and the first case in Kerala was reported in 2020 in a medical student who came from Wuhan in China and was confined to the Trichy Medical College. Our institution was also an active participant in the COVID-19 treatment program. We were also part of the government network, and when the GH in Ernakulam and the Kalamassery Government Hospital was full, they used to send patients to us, and free treatment was offered, and high mortality was seen in all the cases. At that time, while managing these patients, I had a doubt, was it the same phenomenon that I had seen in leptospirosis? Could it be steroid responsive? But I was hesitant to use steroids for this reason. I think all of you will agree that traditionally from MBBS days, we have been taught that never use steroids in viral pneumonia because it will increase inflammation. It is taboo, you should not use it. So I hesitated, but all this changed when the recovery trial was published in 2021, where they showed that dexamethasone can be safely used. And this was probably one of the first studies which showed that steroids can be used in a viral pneumonia. Now this gave me confidence to write up an opinion piece. So I sent an opinion piece to Tropical Doctor where I compared both COVID-19 and leptospirosis, and I gave my opinion. It was the cytokine storm in both, only that in leptospirosis the term was not used. And I have to admit in all humility, by this time I had also come of age. I started publishing articles in foreign journals. I had learned now not only the science but the art of publishing. And part of the reason is that after joining for my present job, I took a course from the Indian Institute of Public Health in biostatistics and epidemiology because I wanted to learn how to write an article. And we followed up with another study, which was an actual original study where we compared COVID-19 and leptospirosis, and it was published in the Journal of Family Medicine and Primary Care, which is a PubMed index journal. Here, we found that there was a lot of similarity between the two, but in COVID-19, it took a longer period for the clearing of infiltrates. That was the main difference we found out. Though I had written up the article, I gave the honor of the first authors to my assistants. They were in need for a paper because as per KH's guidelines, you need a paper for publication, and I didn't need any more papers. So, the level of evidence, steroids and ARDS, COVID-19 level 1 evidence, because including the recovery trial, they were all good trials. As far as leptospirosis is concerned, till now we have only observational studies. No good studies have come out. So the question is, will we ever get a level 1 evidence for steroids in ARDS due to leptospirosis? My opinion is very unlikely because we have so many observational studies. No IRB or IEC will give a clearance for such a study. So I will borrow one sentence from my own opinion article. Absence of evidence cannot be considered as evidence of absence. Just because there is no absent good studies, it doesn't mean that it doesn't exist. Now, coming to steroids in general regarding ARDS, so far I was speaking about leptospirosis. Now, this study I already mentioned, one of the first studies in the world where they used steroids in ARDS, and like I told you, they didn't support the routine use of methylprednisolone, so I put a red flag for that. Then in 2017, another guidelines came from the Society of Critical Care Medicine and the European Society of Intensive Care Medicine. Both these societies are well accepted throughout the world, the guidelines are well accepted. For the first time, they gave a partial recommendation. In early ARDS you could use, so that was an yellow flag. But they still did not have any mention of viral pneumonia and no specific mention of any tropical infection. The next study, and regarding the previous study, one more thing which I would like to remark is, mind you, this was in 2017. Had this guidelines mentioned that you could use steroids for viral pneumonia, probably we wouldn't have much death in COVID-19 because COVID-19 came in 2019 and people did not use steroids until 2021 when the recovery trial was published. So a big gap was there, and I think so many lives could have been saved had we had this guidelines mentioned about viral pneumonia and people would have used steroids in COVID-19. So the next guidelines came in 2021. Actually, this came when I was preparing this talk a few weeks back, in May last 2024, May, and for the first time, the Society of Critical Care Medicine have suggesting that you can administer corticosteroids to all adult critically ill patients with ARDS, irrespective of the stage or the etiology. The term early has been removed, and part of this reason is because of COVID-19, but again, no specific mention of any tropical illnesses. Now, the one point to ponder which I leave with you is, will Western guidelines work for tropical problems? Should we not generate our own data like I have done? Now, while preparing this talk, I had an idea. Why don't I go back to my two patients and see what or how they were? But it was easier said than done because both of them came from the higher ranges of Idukki district, and their phone number, which was the landline, was no longer active. Here I should acknowledge the help given to me by assistant Dr. Binita Baby. I don't know if she's here. She actually comes from Idukki, and she, along with her friends and family, literally went on foot and traced the two families. The first one with whom we made contact was Elias, but unfortunately he was no longer there. He had died in 2010. His son Biju told me that his father died of an attack. He was already a coronary artery disease patient, but he was kind enough to send a photo of the patient to me. The next patient, Mr. Vipin, I could get his number and I contacted him over the phone, over the cell phone, and I was very happy to hear his voice, and I guess he was happy to hear my voice too. I asked him only one question: have you been to a hospital or did you have any major problems after the incidence of leptospirosis? He told me, I think I expressed it in Malayalam, that's what he told me. സാറേ, ഞാൻ അന്നത്തെ എലിപ്പനിക്ക് ശേഷം ഒരു പ്രാവശ്യം പോലും ആശുപത്രിയിൽ പോകേണ്ട വന്നില്ല, കോവിഡ് വന്നപ്പോൾ മാത്രം. പക്ഷെ അത് വളരെ മൈൽഡായിട്ടുള്ള അസുഖമായിരുന്നു, അതുകൊണ്ട് ഞാൻ വീട്ടിലിരുന്ന് മരുന്ന് കഴിച്ചു. That's what he told me. And I asked him for a photo of his, and he was kind enough to send me his family photo. Now, this is after 20 years. This was in 2004, this was in 2024. He is running an inverter business in Idiki. In fact, I also thought, why should he run an inverter business in Idiki, where we get all the power from? But he's doing very fine. Now, why I showed these two patients is that because there has always been a controversy, does ARDS produce long-term sequelae? At least in leptospirosis, and I think the verdict can be safely passed, it does not produce. And this second patient whom I showed is a classical example. Regarding COVID-19, long-term sequelae are there. Even in our study, we have shown that the slow resolution of infiltrates. Now, as of now, I have around 31 papers. It's a modest number. I know there are people here who are more than that. 21 in foreign journals and 21 in PubMed index journals. And among these articles, if someone was to ask me, Dr. Abraham, which is your best publication? Without hesitation, I will say my worst publication remains my best publication. Worse because of the NEGM criteria. And why do I say that my worst publication remains my best publication? Because of one important reason, which I hold very dear to me. And this was that publication. And why? Because of this reason. It saved human lives. And now, looking back, I will summarize in one slide in the form of a timeline. The green signal is recommended, yellow is partially recommended, red is no recommendation, not recommended. 2005 or rather 2004, when we did our study, we recommended you can use steroids in leptospirosis. Come 2006, the ARDS network study comes, the last study, no recommendation. 2006, the Indian guidelines, no mention of steroids. In 2010, Philippines comes out with its guidelines on leptospirosis, and they quote my paper that we can use steroids in leptospirosis. The second Indian guidelines, 2013, no mention of steroids. 2015, the next one, again, no mention of steroids. 2016, the Sri Lankan guidelines come out and they again quote my paper. In 2017, the SCCM ESI, which I told, brings out its guidelines, and for the first time, they partially recommend use of steroids in ARDS. And the Kerala guidelines, which I showed you, I'm not sure about the date, but they don't recommend. The 2022 guidelines, excellent guidelines, for the first time, they mention, Kerala government says that you can use steroids in leptospirosis. You can just find the time gap, 2004 and 2022, nearly 15 to 20 years. And finally, the recent guidelines that came out recently in 2024, when SCCM recommends you can use steroids in all patients, irrespective of the etiology. So actually, with this, a lot of controversy has been removed. So much ambiguity has been removed. Now, if you look at steroids in ARDS, especially in the circle of critical care physicians, everyone is celebrating. Yes, steroid works in ARDS. But we have been using steroids in ARDS leptospirosis for the last 20 years. And to me personally, it has been a very satisfying journey. Thank you.